Encephalitis is the inflammation of the brain parenchyma. Causes are infectious and non-infectious. Infectious causes includes viruses. These are the viruses: herpes simplex 1-2 enterovirus, mumps, cytomegalo, EBV, HIV, measles, influenza, arbovirus. And the bacterial causes could be mycoplasma, rickettsia, histoplasma, right? And there could be some protozoa like toxoplasma gondii and also fungi. Non-infectious causes includes autoimmune reactions, metabolic disorders, and toxins. Okay, so we can suspect encephalitis if there is a viral prodrome that is followed by irrational behavior, then altered conscious state, and then possibly a cranial nerve region, right? So the clinical features would be constitutional like fever, malaise, myalgia. Meningeal features like headache, photophobia, neck stiffness. Cerebral dysfunction disorders like altered consciousness, confusion, drowsiness. Personality disorders, irrational behavior, seizures, coma, and focal neurological deficits, right? So investigation, and for investigation we will go for lumbar puncture to analyze CSF for signs of infection, CSF PCR for viral studies, CT scan to assess brain structure and inflammation or like cerebral edema, gadolinium enhanced MRI, EEG. EEG have a characteristic wave in encephalitis. Treatment is usually supportive, but if we suspect herpes simplex, we will give IV acyclovir immediately. Autoimmune encephalitis is actually a newly identified neuropsychiatric disorder. It has a prodrome of fever and headache that is followed by days or weeks of psychiatric behavior problem with bizarre problems and movement, confirmed by blood and CSF. Brain abscess is a localized collection of pus within the brain parenchyma, often caused by infection, while subdural empyema is a collection of pus located between the dura mater and the arachnoid mater. They both present as a space occupying intracerebral lesion suspected in any patient with a raised intracranial pressure. Raised intracranial pressure is very important aspect here. Infection is usually spread from nearby structures like ear, sinus, dental, periodontal, or through a trauma like a skull fracture. Or infection the bacteria from the other part of the body can travel through the brain stream and reach the bacteria, for example, endocarditis or bronchiectasis. Clinical features are that of increased intracranial pressure like headache, nausea, vomiting, altered consciousness, papilloedema. Other could be like focal neurological signs as hemiplegia, dysphagia, ataxia, like seizures, fever, signs of sepsis somewhere else like teeth or endocarditis, or it could be like otitis media or sinusitis. Complication can be a brain herniation or neurological deficient, predominantly due to increased intracranial pressure. Investigation includes imaging like MRI or CT scan to visualize the abscess, or ESR, CRP, or blood culture to detect the specific organism. Treatment would be, first of all, we'll give the urgent neurosurgical referral. Aspiration or biopsy is essential to guide antimicrobial treatment, and antimicrobial treatment would include metronidazole IV and a cephalosporin, right? Cephalosporin could be ceftriaxone IV. In immunocompromised patients, the reason could be toxoplasma, nocardia species, or fungi, right? So, in case of fungi or nocardiosis, it is treated with other agents other than cephalosporin. Spinal subdural abscess is the accumulation of pus in the subdural space of spinal cord, while epidural abscess refers to the accumulation of pus in the epidural space of the spinal cord. These are the serious conditions that lead to compression of the spinal cord and nerve roots, causing neurological symptoms. The usual organism is Staphylococcus aureus. Symptoms are usually due to the compression of spinal cord. It could be back pain, increasing back pain, and radiculopathy, percussion, tenderness over the spine, or evolving neurological deficit like gradual leg weakness and sensory loss. Fever may be absent. Causes are usually infectious spread, usually arise from the hematogenous spread through the bloodstream from distant infections such as skin, associated infection of the furuncle, decubitus ulcer, adjacent osteomyelitis, dysitis, and other, or from the back trauma with hematoma, or from the post subdural epidural anesthetic block, right? So the investigations would be blood culture to sort out the organism, that is usually Staphylococcus aureus, and the MRI scan to localize the abscess and spinal cord pressure. Management, first of all, we will give urgent neurological referral, right? And surgical drainage may be required to remove the pus and relieve the spinal cord compression, and antibiotics targeting the specific causative microorganism, right? These would be the antibiotics. Prions are the proteinaceous infectious particles that do not have nucleic acid, right? The classic example is CGD. Other forms could be Kuru, fatal familial insomnia. Creutzfeldt-Jakob disease is an example of Crohn's disease. Usual transmission is from contaminated human tissue like corneal graft, cadaver, pituitary, human gonadotropin, or eating contaminated beef, right? Fatigue, psychiatric symptom, myoclonus. This is the classic presentation. Fatigue, psychiatric symptom, myoclonus. It starts with rapidly progressive dementia. Early symptoms may include memory problem, behavioral changes, and coordination difficulties, right? Then there are neurological symptoms like myoclonus, muscle spasm, or problem with coordination and balance. There could be fatigue and somnolence. Patients become immobile, mute, and bedridden in the later stages of this disease, okay? And this disease also causes rapid deterioration in cognitive function, leading to severe dementia and other features like ataxia and chorea. So the first thing is progressive dementia that starts with personality change and memory loss and even loss of speech. Neurological symptoms like myoclonus, muscle spasms, problem in coordination and balance, fatigue, somnolence, all of these things. Clinical evaluation is based on patient's medical history, symptoms, and neurological examination. Laboratory test would be the MRI that may reveal characteristic change in the brain, usually thalamus. CSF to analyze CSF analysis may show elevated levels of specific protein associated with this disease. EEG or brain biopsy after death is the ultimate confirmation. There is no cure for this disease, we only give supportive management. Poliomyelitis is caused by picornavirus transmitted through the fecal-oral route. Myelitis means inflammation of the spinal cord. This is very specific spinal cord anterior horn enterovirus. This condition has flu-like syndrome, then pre-paralytic state, paralytic state, and also post-polio syndrome. First of all, patient will develop flu-like syndrome like with fever and sore throat, and then pre-paralytic stage with nausea, vomiting, headache, neck stiffness, then paralytic. It will have lower motor neuron lesion, may include spinal polio, especially of lower limb or bulbar polio, and respiratory failure, no sensory loss. The latest stage is post-polio syndrome. Some individuals who recover from acute polio may experience new muscle weakness or pain many years later. Diagnosis is with virus studies of throat and feces culture through culture and PCR, serology, and CSF. Prevention is with the vaccination. The polio vaccine is administered orally, oral polio vaccine, that is OPV, or through injection, that is inactivated polio vaccine, that is IPV. Complications are paralysis and respiratory failure. Neurosyphilis can present at any stage of syphilis. It can present as asymptomatic syphilis during the interval between secondary and tertiary stage. It can present as meningitis, including acute basal meningitis and meningovasal syphilis. Meningovasal syphilis can present with the cerebrovascular accident, and it can also present as staph dorsalis, causing meningoradicalitis with degeneration of the parenchyma of the spinal column of the spinal cord and involvement of pupils. Features include lightning pains, Charcot joint, ataxia, and neurotrophic ulcer. Right, and general paralysis of the insane with markedly personality changes, dementia, dysarthria, and seizures could be presented. Tuberculosis can infect CNS in some ways, as meningitis, tuberculoma, and other conditions. HIV may be direct with primary infection causing encephalopathy, myopathy, or acute atypical meningitis, or via the opportunistic infections that include CNS toxoplasmosis, cytomegalovirus, herpes simplex, varicella zoster, and others. Worm infestations can occur that could include tapeworms, Taenia solium, Echinococcus, that is hydrated, and Schistosoma. Some other infections that present with seizures include botulism, tetanus, rabies, Hansen disease, that is leprosy. Here comes the end of the chapter.